We are dealing with a burnout problem in our profession, and I think it'd be really helpful for viewers to know if you invest in your career and you find your passion, whatever it is, whether it be interviewing or going the admin route or going the research route, or for me it seems like going the clinical route and giving people outstanding physical therapy experiences, you're going to be rewarded.
Andreas, welcome to the show.
Appreciate you.
Looking very dapper in the suit.
Yes, sir.
Formal. Presenting here at AMPT.
Yeah, we just finished our presentation on spine-related lower extremity pain, going over the 2023 international consensus, and that went fantastic. A really full crowd, tons of amazing questions. And as I was waiting for this interview, I'm still getting questions about it.
It's got to feel good, right?
Yeah, I think it's very important to bridge the gap between what physicians are looking at for defining specific terms in the spine world, and then how can we contextualize that with in the physical therapy world.
Yeah, you've got a non-traditional background in your career a little bit. Like, walk me and the audience through that just a little bit.
Yeah, so born and raised in Hawaii. Going into college, I didn't know exactly what route I wanted to do, so I did psychology, very broad.
Brilliant move before coming to PT, in my opinion.
Yeah, it does pay dividends now. And as I was in school, I was dealing with a lot of injuries and going to physical therapy, and unfortunately, I actually had some bad experiences where I thought physical therapy should work for me, but unfortunately it wasn't quite working. And then I'm like, oh, well, maybe I can just see the clinic owner because I'm seeing the non-owners. Maybe I just need to see someone who knows a little bit more about the condition. And I remember seeing the clinic owner, and he looked at me, and I'm more on the thinner build side, and he's like, oh, man, you got to just get stronger. Just start doing push-ups. And then he was on his phone taking business conversations, and I just felt like, I got to figure this out on my own.
This ain't it.
Yeah, this isn't it. So I didn't switch over to PT in school because I was working full-time and paying for my home, and I went into a sales career, and the injuries were still lingering on me, and I said, look, I got to do something more meaningful with my life. So in 2018, I dedicated my life to improving patient experiences in physical therapy.
Where does that start? I mean, I guess you had the experience of what bad was. So then if you're going to improve experience, it would be understanding what the experience or the many experiences are, and then finding those fault points, finding where it doesn't actually meet the mark.
Yeah, so it's really identifying what is the potential etiology, and what are we doing in clinic to be very systematic about if someone has a given impairment, how are we prescribing to improve that impairment, and how are we tracking the progress of improving that impairment over time? Because we can find impairments on many people, but is that impairment relevant to that person or not? And unless we are very precise about tracking it, we will not know. So through my education, I worked really hard with learning as much as I could in PT school, and then I did some postdoctoral training programs, which I found extremely helpful, orthopedic residency at Mayo Clinic, and that gave me big picture structure on Mayo Clinic is all about providing the patient the best experience. Their motto is the needs of the patient come first, and that directly lines up with my motto. So I spent a year there, and then I ended up going to the University of Southern California and doing a spine fellowship, which initially I wasn't sure what to expect, but it was one of the best experiences of my life. My mentor, Dr. Justin Lance, he cares about PT a lot, and he really pushed me. My first mentoring session, he took me out of it, and he gave me a 10 to 15 minute great spiel on like, what are we doing here? We need to bring you to the next level. I think he recognized that I cared a lot, but he needed to take me to the next level, and I think he was able to accomplish that. And then just this last year, I finished my orthopedic fellowship at Duke, and now gotten exposed to 3 of the better systems in my opinion in our country, and especially with USC and Duke in the physical therapy world. We know how many great people they have at both of those institutions. So now I got to blend all of their opinions into my own clinical practice, which I think has been really helpful.
Isn't that great? It's more of a personal pick from the buffet and less of a recipe.
Yeah.
In your career, you're able to see a bunch of things and take the things that you like out of them and apply them.
Right. I want to see what is this specific PT doing to get people better that other PTs are not doing, and then how can I take that from the many mentors I've had and provide many patients with all of these options. There's only so much we can do with PT, but there is quite a bit we can do with PT. So getting to know what have these experts found to really change their practice in terms of patients who may not have otherwise gotten better, but they were able to flip the switch for that patient. And in the past, that was me, right? So I wanted to be there for patients who used to be in my shoes and be able to flip that switch for them.
Yeah. So you've worked across multiple areas and systems, as we just talked about. What do you think makes a great manual therapist in 2025 and beyond? What's that look like?
So being very intentional. So with manual therapy, we start with our assessment, and that's really in the history and the physical when we first meet the person and they're going through a consultation with us. So first by defining the area and type of symptoms that they need help with. And we need to be very specific about all of the areas and all of the types of symptoms. Once we've accomplished that, we then need to talk into, the patient will lead you either into the history of the symptoms, which is going over the timeline that they had since the injury occurred, or they'll talk about behavior of symptoms, which would be kind of like our sins that we learn in physical therapy school. And if you can work with the patient through the history and then the behavior of symptoms, you come to this nice differential diagnosis, so you know exactly what to do in your physical exam. The way I've been trained is to look at clinical patterns and try to identify, is there a given pattern for a given condition, and then what can I do in my physical exam that will either increase or decrease the preponderance of evidence for that pattern. And in the clinical exam, the physical side of it, we have to be very specific about, let's say I'm doing a CPA on someone. Before I even touch them, I might explain the purpose. I'm looking to see if this will change what you're experiencing, and then talking the patient through, okay, now I'm going to do it repeatedly. Sometimes this can make it worse, sometimes it can make it better. I just want to know what you're experiencing. And then getting that information so we have much more reliable data collection. I'm very into objective numbers and objective data collection. And if I can collect all of that in my initial evaluation, I've set a very good baseline about what this patient's current capacity is and how movement and things like that affect what they're feeling. And that allows me to come up with a much more individualized and precise plan.
You can measure it over time.
Yeah, exactly. And then when they come back, I have a whole to-do list on these are the things I need to address. And then we have our toolbox. Is it a thrust manipulation? Is it more gentle, grade 2? Is it dry needling? What is it that we need to do to address this? And then what is the patient doing actively at home to maintain or improve on some of what we've been working on in clinic?
Yeah.
So it all comes together. And one of the most important things is your patient going to return? And if we can get patients to return to us and trust that we have a system and a plan, there's a much likely better chance that they are indeed going to improve over time. And if they can't improve, then we should probably have some theories about why that is. Is there a certain clinical pattern that's maybe more medical, surgical, that we need additional help from our physician colleagues to manage? And then can we make the appropriate referral so that patient can be taken care of?
Sounds like you're building a better practice for the guy who was just told to do push-ups while the clinic manager was just taking phone calls.
Yeah.
It sounds like it left an impression on you.
Yeah, certainly it made me realize, especially after going through all this training, the more effort I put into improving my systems, the better outcomes patients have, the more satisfied they are. We are dealing with a burnout problem in our profession, and I think it'd be really helpful for viewers to know if you invest in your career and you find your passion, whatever it is, whether it be interviewing or going the admin route or going the research route, or for me it seems like going the clinical route and giving people outstanding physical therapy experiences, you're going to be rewarded.
Yeah, that's good advice. If every clinician at AOM took one idea home from the things that you were sharing here, what would you want it to be?
So it depends on what context we're talking about. So I think
you could have more than one. I'll allow it.
Yeah. I think as our profession evolves, we tend to go in different directions, and other professions also go in different directions. So, for example, physicians are starting to work on getting a little bit more specific with things like diagnostic blocks and ablations and trying to solve the problem of low back pain, which is the number one problem and disability in our country. And as they begin to solve these problems on their end, I think we also need to start realizing that they are becoming more specific, and potentially we can start to identify more specific patterns in our own practice. And that's where our talk today highlighted on the 2023 International Consensus from Schmidt and Payne 2023. So they talked about somatic referred pain, radicular pain, and radiculopathy, and how these hopefully eventually can be classified as distinct entities. Whereas right now, a lot of times in the research, somatic referred pain is just classified as either non-specific low back pain or incorrectly classified as neurogenic low back. And then radiculopathy and radicular pain are often just clumped together. Whereas radiculopathy is a problem of a loss of nerve function where we're getting hard signs such as loss of myotomy strength, dermatome sensation, or reflex. And the radicular pain would be more of increased neural function, so hyperexcitability. We're thinking some sort of pathophysiological process like inflammation that's creating lancinating pain, narrow beam, and it's more so pain dominant versus the true definition of a radiculopathy would be a painless condition.
It feels like you've met a lot of really interesting people across your career. Like you've mentioned several of those people by name. Who's someone that the audience should know more about? Who's someone that the audience should look into for whatever reason, in your opinion?
Yeah, I've met great mentors at Mayo Clinic. We had Ryan McCoy, John Leschitz, and Tava Buck, and those were my main 3 mentors. And Ryan really helped take me under his wing and just show me what it is like to provide a good experience from making the patient feel comfortable. And then we moved on to USC, and I had so many great mentors there. Justin Lance would be someone I think is a rocket ship for our profession, and he's someone we need to take a close look at. He works a lot with NAS, and he's trying to bridge the gap between what physical therapists do and what they do at NAS with the physicians. So can we start to speak the same language? Can we all start working together to solve the problem of low back pain and neck pain? And so at USC, I also had other great mentors. We have Yogi Matharu there. He's really big into admin. He runs their whole clinics there. We have Dan Karajas. He taught me a lot about more about the patient experience. He's one of the nicest people I've met. And then at Duke, we have my primary mentor throughout the year was Mike Raymond. And he really helped teach me. We talked about the history side of collecting an interview, and then he helped with the whole funnel approach with being very good with the physical exam and triaging to make sure it's not a sinister condition, ruling out competing areas, and then really honing in on the specific area. Before you're, for example, examining a knee, you should make sure they don't have any sinister pathology. So those are all great names. And at Duke, our coordinators, Preston Roundy and Cody Belay. I moved to Duke. I didn't know anyone there, so they really made me feel comfortable. So many good people I've been exposed to. If the answer is just one, I wouldn't be able to answer it with one. So
I love it.
Those are all the ones that come to my mind.
Perfect. Yeah. All right, last thing we do on each episode, we call it the parting shot. What's the last idea, concept, quote, whatever, mic drop moment, soapbox? What's something you want to leave the audience as we wrap up?
Yeah, the audience needs to, if you're a physical therapy student, if you're a current physical therapist feeling burnt out, if you start to chip away at investing in your career and learning more about the human experience and diving into what does it mean to be an expert physical therapist, you're going to be rewarded. Your patients are going to be very happy. If they're not happy, you're going to probably have better hypotheses about why they're not happy. And overall, you're going to really enjoy this career. And I'm so grateful to have this career. I love what I do.
Sounds like it.
Yeah.
Andreas, appreciate the time. Thanks for doing what you do, man.
Absolutely.
Thanks for listening to Hands On, Hands Off, the official podcast of AOMPT. Subscribe now so you never miss an episode. And connect with us at aompt.org or at AOMPT on social. Opinions are those of the guests and not official AOMPT policy. See you next time.